COVID disaster preparedness and management in COVID-19 pandemic. So for just 1 second, please. Yes, so the outline of the presentation will be the definitions. We'll go a little bit in the timeline of the declarations for the pandemic, and then look at the WHO disaster management protocol, and finally a checklist if we have time. So the definitions: disaster, also called a mass casualty incident, has three main criteria to it. It interrupts the normal functioning of a community. It exceeds the coping mechanisms or the capacity of the community. External assistance is often needed to return to normal functioning of the community itself. So the disaster can be man-made or natural. So it is to be noted that when we talk about disasters, we're talking about geophysical disasters, which are like earthquake, or meteorological ones, such as storms or floods, or climatological ones, which are heat waves, and obviously the ones that we are concerned with, which is the biological one, which starts as an epidemic. The epidemic can then spread and turn into a pandemic, which will be a global outbreak of a serious infection disease. So the usual natural disasters, such as an earthquake, will result in large number of trauma patients, which will require trauma management, including airway management, breathing support, circulatory intervention, and wound care. Whereas the epidemic itself, the biological one, will result in a large number of infected patients, which will require infection control measures, medical treatment, and the use of antimicrobial drugs and vaccines. So we can see that there's a little bit of overlap in the COVID-19 pandemic, because it actually requires airway management and infection control measures. So the MCI, the mass casualty incidence, is leveled in 6. So we are already in level 6, which is long-term operational periods. So these are the potential victims. Level 5 is more than 200 victims. So the declarations by the WHO in January 2020, they announced the outbreak to be a public health emergency of international concern. And only in March 2020 was it declared to be a pandemic. So that gives us about 3 months of preparation to actually tackle the problem. So in March 2020, the Minister of Cooperative Governance and Traditional Affairs of South Africa initiated from the Disaster Management Act, which was created in 2002. So this act had 5 main objectives: the declaration of national state of disaster. It wanted to assist and protect the public, provide relief to the public, protecting property, preventing and combating disruption, and also dealing with destructive and other effects of the disaster. So from all the early outbreaks in January, which happened in China, or in February happened in Italy, these are the lessons we should have learned before it actually started here. So there was a clear absence of public health emergency response. So the emergency response system is supposed to be making a contingency plan and coordinating the anti-epidemic response action. There was also a lack of adequate manpower. So these were known to be especially nurses and doctors with critical cares, and definitely improper resource planning regarding masks, personal protective equipment, PPE, or ventilators. So some articles talk about the Cassandra syndrome. So the Cassandra was a daughter of King Troy during the Greek War, the Trojan War, and she was cursed with a predicament. She was made aware of all the future events of the war, but all her warnings were disbelieved by everyone she was trying to get to. So pretty much, the disaster in COVID-19, the disaster usually that happen, natural disasters, involve patients that are severely injured, bleeding or screaming, and brought to the hospital by EMS or people trying to help. But the COVID-19 pandemic was something different. Patients themselves would come to the hospital and starting as a mild cough and usually progressing into severe fever or respiratory distress. So the situation initially generated some confusion and definitely underestimation of the real weight of the problem, especially in the early outbreaks. So the lesson to be learned is to never underestimate a disaster. So we'll take a look at the WHO disaster management protocols. So it has four main components. So it talks about mitigation. Mitigation would be to manage a biological disaster or epidemic more properly and effectively so that the healthcare system can reduce the disaster risk before it actually happens. The second point is preparedness, which is to provide training and drills to equip the healthcare team and public adequately before the epidemic outbreak occurs. So the two first steps is before the disaster actually hits us. Then we'll talk about response, which is carrying out medical rescue, which entails dispatching a public health emergency response team to control and treat the infection. And finally, recovery, which is restoring and reconstructing physical, psychological, and social health, facilitate those infected patients and infected healthcare workers. So from here, we'll try to apply those targets of WHO in a healthcare setting. So the risk, the mitigation of the problem itself. So mitigation is a pre-disaster risk reduction phase. It includes patient education, public health emergency response team, and manpower and resource planning issue. Let's try to look at this in the COVID-19 setting. So this doesn't really concern us. Patient education, some reports talk about trading and consumption of wildlife. So I think they're talking more in an Asian setting. So in this concept, public awareness is key. What we should learn from this, though, in a setting of South Africa, is that non-compliance of the population to new measures should never be underestimated. If required, reinforcement of measures must be carried out with setting of new laws to avoid disruption and further disease spread. We saw this with the mask that people were not wearing initially, but then when the law said there will be a fine, everyone started wearing it. So the public health emergency response team. So usually the countries that need them the most are the ones who don't have them, and those are the developing countries. And if they have them, they are underfunded and unstaffed. So setting up of such a system is crucial, especially to investigate appearance of new cases, coming up with corrective measures relative to initial measures that were taken by other healthcare settings, or even if needed to ask for aid from external sources to achieve optimum preparedness. We'll see as long as we go through the PowerPoint how the emergency response team is crucial for the proper functioning. So for manpower and resource planning, the things that we saw the most from retrospective reports is that there were inadequate nurses with intensive care experience. So um, each department will have to work in conjoint with the emergency response team to add up the numbers of healthcare workers available. And that's exactly what we did here. So training prior to actually reaching the response phase is critical here. So second point is inadequate mask and PPE. So the hospital itself should activate emergency production line of factories if it can to produce additional resources, and those would be masks, PPE, and ventilators to meet the needs when the outbreak actually reach us. Then lack of effective control guidelines. So if needed, those should be actually created or standardized and adapted. So this would include standards for isolation room setup, which tends to be forgotten. And then lack of quarantine centers for suspected cases and lack of temporary hospitals for confirmed cases during the initial phase of the pandemic. So the University of California had one of the biggest challenges where they talk about testing. So the whole drive-through testing comes from them, which people think it comes from South Korea. It worked the best there, but they are the one who created it. So it's called the Asper Tracy Technical Assistance Recourse. So the advantages for it were it's got speed. So sample collection takes about 1/3 less time than the usual time in casualties. Staffing, less personnel needed, so less exposure to the infection. Physical distancing, which would limit transmission from the disease itself, and definitely convenience, which would avoid long waiting lines or requirements of massive parking spaces. So it is also crucial or a good practice to protect public well-being in the mitigation phase. So to unload the economic burden of the citizens and the government during and after the pandemic, you should encourage more citizens to have medical aid. So as the disease have longer period of hospitalization and rehabilitation, pursuing medical insurance may help cover of some of the medical expenses and relieve us, especially public hospitals. So an ounce of prevention is worth a pound of cure by Benjamin Franklin. So that would be the preparedness phase of the protocol. So this is known as the pre-disaster preparation phase, which is also known as capacity building. So most of these are learned from past experiences, such as SARS in 2013 or Ebola in 2014. So, so the key thing of it is to protect our healthcare workers, which are essential to the proper functioning of the rest of the protocol. So adequate training and drills should be offered to our healthcare workers as well to the public though. So healthcare workers are more used to infection control measures. The issue is more related to training regarding critical care. So when we're involving, as we said, other doctors from other departments, they should also have basic critical care training. We must also view training not only for the patient benefit, but also for the healthcare worker. So aiming to knock two birds with one stone, when we're training for high-risk procedures, such as high-flow machines or insertion of ET tube, mechanical vents, and definitely CPR, those trainings should include measures of how to protect the healthcare workers and not be haphazardous. So countries affected by natural disasters, including earthquakes, fires, and aviation accidents most of the time, have more drills related to those events. But when it comes to infection control, very few countries actually do drill. So drills, they are necessary to empower everyone to have the capacity to combat the infection. So how to gain the most from drills? So they talk about we should be able to dispatch healthcare team to a simulated site of the outbreak, fully equipped for any emergency, which is usually the problem. We have the amount of staff, but we don't know what to take, or we're there and then we miss stuff. Mobilizing medical resources such as masks, PPE, and ventilators. So the transport for equipment should be ready. Setting up quarantine centers to do screening and triaging for suspected cases, and setting up a temporary hospital for managing confirmed cases of infection. So like already initiated 4 years. Healthcare teams should also be very good at job division to decrease the amount of stress on each individual so that also we achieve optimum patient care service in minimal time. Another thing to take into consideration in the preparedness phase is the lack of education to the public. And as we said, public awareness is key in such times. So simple measures like hand hygiene is usually very acceptable to the public. But when it comes to new strict measures such as quarantine or social distancing, they are very reluctant to it because it disrupts your normal daily life activities. So use of mass media such as social media, television, radio, to promote the concept of cuff etiquette, social distancing, um, home quarantine, and avoid social gathering, and also to stop eating wild animals. So social media, it is it is crucial though to think about it from two perspectives. There is a lot of fake news or conspiracy theories on social media. So as a healthcare professional, it is our duty to ensure population reassurance and better adherence to protective measures. So the crisis response. So moving on, this is intra-disaster emergency response phase. So now we're in the crisis and we have a lot of people coming. So reports, especially from China, say there was a high inadequate manpower and resources during the initial response phase. So this is a phase to confront and combat the epidemic directly. Retrospective reports showed that the rapid increase in number of COVID-19 patients outweigh the medical capacity of many countries and regions. And many poor countries or underdeveloped regions had to request for international help for assistance. So the reasons, as we said, are manpower. So this result in difficulties in triaging and stabilizing suspected COVID-19 patients, and would also delay the provision of actually definitive care and evacuation plan to isolated areas. So now this would just pile up everyone in casualty and worsening the toll on the healthcare system. Again, if a public healthcare response system or network had already been set up in the mitigation phase, none of this would have happened. So the solution to this is to arrange adequate manpower, coordinate the overall anti-epidemic activities, and suggesting different treatment modalities. Um, all right, so the emergency response team is also responsible to estimate the coping capacity of the community so that they can report to a higher committee from the government to have better planning to manage it. So the pandemic itself definitely has a heavy workload among mental health care teams, and we're talking about our psychiatry department because most of the healthcare worker and patients now suffer from stress disorders, acute stress disorder. So they also advise when setting up our emergency response team. So they also request to include training on psychological first aid to all the doctors being involved in the emergency response team so that this can relieve our mental care department from the overload of patients. So the response plan itself seems like very little to comment about because now we're just trying to reach solutions day by day. Whereas if we actually tackle the two previous steps thoroughly, we wouldn't be worrying too much here. So then now we moved on from a response phase and we'll be in the recovery phase. So this is a post-disaster recovery and reconstruction phase. This phase is to facilitate patients, but also our infective healthcare workers to recover physically and from their psychological stress and social problem. So rehabilitation teams usually are not included in the initial response team, and it should actually happen. Because what happens otherwise is nurses are the ones who are rehabilitating the patients in Ward A, like trying to improve their muscle power and physical beings. So this is extra work for our nursing staff. Who actually should be devoting all their time for nursing care, which is already very time and effort consuming. So when we talk about rehabilitation team, we're talking about physiotherapists, OT, but also there is a social issue problem with a pandemic. So long-term hospital stay and poor physical status will definitely result in unemployment or an inability to support their family for a long while. So from a holistic approach, this rehabilitation team should definitely include psychologists or rehabilitation therapists and also medical social welfare department to help bridge the gap during those rough times. They also advise to set up a literature committee because since it's a novel disease, there will be thousands of articles being released every week. So setting up such a committee would definitely try to scan through and retrieve concise and efficient knowledge that is necessary for our setting, and also to stay up to date and to avoid redundant and or obsolete management. So for a South African setting, this is Shaheen Mehta of the Infection Control African Network suggested that the rural communities, most of the time, listen to traditional healers for public awareness because either they don't have TV or it's their lifestyle. So they believe from past events that traditional healers have a much greater impact on public awareness and they should be involved as early as possible, especially during the mitigation, during the preparedness phase. and have them reach the population for habit change. So this checklist, it's quite an extensive checklist. It's got 6 pages, but I think it would have been very useful during our preparedness phase. It talks about everything from setting up fires to how to cope with stress and organizing routes for safe transport of patients. This was done by the California hospital, a private hospital. So if you guys have time, you can check it out. So I'll finish on this. This is Rahm Emanuel, a mayor of Chicago. Said you should never let a serious crisis go to waste. And by what he means by this, it is an opportunity to do things you could not do before. These are my references. Thank you.